In this video, we will cover intestinal obstructions. We will start with an overview of mechanical obstruction and then briefly discuss the different causes of mechanical obstruction, including herniation, volvulus, intussusception, and adhesions. We will then discuss congenital disorders leading to obstruction, including duodenal atresia, Meckel's diverticulum, and Hirschsprung's disease. To start, mechanical obstruction is a physical obstruction of the GI tract. It can occur at any level, but the small intestine is most commonly involved due to its narrower lumen. Patients with mechanical obstruction will present with colicky ab pain, abdominal distension, vomiting, and constipation. The four most common causes are hernias, intestinal adhesions, intussusception, and volvulus. These account for 80% of mechanical obstruction cases. One common cause of obstruction is abdominal hernia, which is a protrusion of the bowel into a serosa-lined pouch of peritoneum. This results from a weakness or defect in the wall of the peritoneal cavity. Acquired hernias tend to occur anteriorly. Types include inguinal and femoral hernias, umbilical hernias, or hernias at the site of surgical scars. Visceral protrusion, most commonly the small bowel, can become entrapped, leading to venous stasis and with eventual strangulation and infarction of the bowel. As we have said, volvulus, or twisting of the bowel along its mesentery, is another common cause of obstruction. The sigmoid colon is involved more often in the elderly, while the cecum tends to be involved in younger patients. One way to remember this is the phrase, "Grandpa Sigmoid drives his vulva while the kids play hide and seekum in the back." Patients will present with obstruction and bowel infarction. Pictured here is a rather large volvulus. These are said to be sausage-shaped masses when the abdomen is palpated. Intussusception also results in obstruction. Intussusception is the forward telescoping of a proximal bowel segment into a more distal segment. In kids, this is thought to be due to lymphoid hyperplasia from an infection. It tends to occur when the terminal ileum, where the Peyer's patches are located, into the cecum. In contrast, adults tend to get intussusception from tumors. Patients will present with obstruction and infarction and the characteristic currant jelly stool. Why we like to name everything after food, I'm not sure. Air enema is both diagnostic and therapeutic in that the intestines are gently pushed back into the proper position. Adhesions are the most common cause of small bowel obstruction. They account for 60% of cases. The etiologies include previous surgery, mets to the small bowel, endometriosis, and radiation. Previous surgery is the most common cause of adhesions. Duodenal atresia is a congenital disorder that results from failure of the duodenum to canalize. It's typically associated with Down syndrome. Patients have polyhydramnios in utero, and abdominal X-ray will show the characteristic double bubble sign seen here. As neonates, they will present with bilious vomiting. So Meckel's diverticulum is another congenital cause of obstruction, and in fact the most common congenital anomaly of the GI tract. It is a true diverticulum in that the outpouching contains all three layers of the bowel wall, and this results from failure of the vitelline duct to involute. Meckel's is said to follow the rules of two. It is found in 2% of the population. The diverticulum is 2 inches long and is located in the small bowel within 2 feet of the ileocecal valve. It presents by age 2 with bleeding, and it can also present instead with volvulus intussusception or obstruction. And the bleeding is due to heterotopic gastric mucosa within the diverticulum that produces acids and leads to ulcers. Diagnosis is made with the technetium-99 nuclear scan, and that just locates the heterotopic gastromucosa within the diverticulum. So the last congenital disorder we will discuss today is Hirschsprung's disease, which is also known as congenital aganglionic megacolon. This occurs in 1 out of 5,000 live births and is more prevalent in males than females. This disorder is also associated with Down syndrome. It is due to a loss of function mutation in the RET gene and leads to failure of neural crest cell migration. That's a key thing they like to ask about Hirschsprung's is the failure of neural crest cell migration. As a result, there is an absent Meissner and Auerbach plexi. These are also known as the submucosal and myenteric plexi. Since these are absent, there is no coordinated peristaltic contractions, so you'll get a functional obstruction with proximal colonic dilation. To diagnose Hirschsprung's, a rectal section biopsy must be performed to demonstrate the absence of the ganglion in the rectum and sigmoid colon. On gross morphology, the aganglionic rectum and colon will actually appear normal or contracted, and it is in fact the normal colon that's proximal to it that gets massively dilated. Again, on histology, you won't have the ganglion cells. So neonates will present with meconium ileus and have absent stool on digital rectal exam. Remember that CF can also present with meconium ileus, so you'll have to differentiate these two. In addition to meconium ileus, patients can also have enterocolitis, electrolyte disturbances, and complications of perforation and peritonitis. Treatment will involve resection of the aganglionic colon and is typically curative.